Welcome to the Morning Medical Update. We all have cholesterol in our blood, but you're about to meet a child whose cholesterol was so high it was coming out of her skin. There aren't many hospitals equipped to handle this disease. Here's Alexis Del Cid with that story.
They put the needles in and then they clean my blood.
10-year-old Aubree Bell knows more about science and medicine than anyone her age should.
When I was 2.5, I got diagnosed with it.
She's had plenty of first-hand experience.
It's about 8.5 hours here and then it's 8.5 hours back.
And even though it's grueling driving to Kansas City every 14 days from their home in South Dakota, causing her parents to miss work and Aubree to miss school, they feel fortunate.
There's a good chance I wouldn't have a daughter anymore if we weren't getting this treatment.
This therapy of apheresis is very rare in the United States for treating this kind of disease. Now we have the largest center in North America. We treat more patients here at KU than all of Boston, New York, Chicago, LA combined.
Aubree has familial hypercholesterolemia, also known as FH. It's a genetic disorder that makes Aubree's bad cholesterol sky high. Medication won't lower it. The only thing that works is this treatment, administered by Dr. Patrick Moriarty at the University of Kansas Health System. It's called lipoprotein apheresis.
The cholesterol goes down in the red bucket.
These machines filter the bad cholesterol from Aubree's blood and then put the clean blood back into her body. But reaching Dr. Moriarty and his team was a 5-year-long process, even though the signs were there beginning when Aubree was just 2 weeks old.
They just said it was probably a fungus or something.
Her mom, Jade, says she noticed orange patches developing on her baby's skin. She says the doctors in South Dakota told her it was because she wasn't bathing her properly.
It was frustrating that I was being blamed.
Over the years, the orange patches got worse, and still, she says, the doctors wouldn't listen.
It honestly almost looks like orange sherbet was the shade of the orange, and it looks like little bubbles, like kind of like a smaller blister.
They looked like an orange peel.
Finally, she drove 2 hours to a dermatologist in another town who correctly diagnosed the orange patches as xanthomas, and further testing revealed something horrifying.
He did do a biopsy and a blood draw, which her cholesterol was almost 1,000 at that point.
There was so much cholesterol in Aubree's tiny body, it was seeping out of her skin, creating the orange deposits.
I always say go with your gut feeling. As a mom, you know when something is wrong, and unfortunately sometimes we have to be our own advocate and push for the answers that we need.
It was Jade's persistence that landed them here for this treatment, a place where Aubree is surrounded by a care team that has really grown to be like family.
They're so nice. They spoil me. Halloween, my birthday, Christmas, Thanksgiving.
And she has big plans for the future.
I want to move to New York and be a fashion designer.
Big dreams. We like to hear that, and these kids doing well. We are so glad to have two doctors who treat children like Aubree here in our studio with us today. And Dr. Patrick Moriarty is the director of the Atherosclerosis Lipoapheresis Center here at the University of Kansas Health System. How are you this morning?
Very good.
And you treated Aubree, and we just saw him there in the story. We're also happy to have Dr. Gita Raghuveer, a pediatric cardiologist at Children's Mercy Hospital here in Kansas City. She is also the director of preventative cardiology at Children's Mercy, and so glad to have you sitting with us today.
Thank you.
Such an interesting case, so let's dive into this. We also planned on having Aubree and her mom Jade here with us today, but they were having some car trouble as they were making that trip, as they talked about, from South Dakota. So we're good wishes to them as they deal with car troubles and all that mess. But we do still want to carry on and talk about this because it's so interesting. And Dr. Moriarty, on that note, we hear that they travel so far. Aubree and her family making that 8-hour road trip to Kansas City every other week for treatment. Do you have a lot of patients traveling to Kansas City to get this treatment?
Unfortunately, yes, we do.
Unfortunately, yeah.
Even some out of state. We have some coming in from New York, actually. And but mainly in the Kansas, Missouri area is our major population of patients. We treat about 80 patients right now for this disease, these diseases. And Aubree was a special case because she was born with, as her mother said, LDL cholesterol, which is the bad cholesterol, over 900. and she had what we call null receptors, so any medications, be it statin or whatever medications, had absolutely no effect on her because she had what we call no LDL receptors, which are resistant to her therapy.
So I want to talk about the treatment for this.
Yes.
Lipoprotein apheresis. You're basically filtering cholesterol out of the blood.
Right.
I want you to tell us a little bit about what that is, and is this a treatment that Aubree is going to have to continue to have throughout life?
Well, fortunately, we hope not. There are new medications, and there is one new medication out right now that successfully lowered her LDL by 50%. But lowering from 900 to 450 is still extremely high. And how the apheresis works, bad cholesterol, be LDL, has a positive charge to it. And this device filters the plasma from the blood. I mean, that plasma is where the bad cholesterol is. And these filters have special charge to it, a negative charge that captures the bad cholesterol. Mm-hmm. Additionally, we also capture inflammatory markers like CRP, fibrinogen, and interleukin-6, which is a major factor in COVID infection, as we found. And it's a euvolemic procedure, so we actually only take out proteins and no volume, so we lower the patient's blood viscosity by 20-30%. And I tell my patients, jokingly, I change their blood from ketchup to tomato juice. So their vascular perfusion, the tissues, is greatly enhanced. So not only are we lowering the risk, they're actually feeling better by this therapy. But as I mentioned, there's a new drug out from a company called Regeneron that has been shown to be quite effective in patients who are this high of resistance to medications. And because of this, she now comes down once a month instead of every 2 weeks, because we've gotten her levels down into the double digits with this combination therapy.
I love how you describe ketchup to tomato juice. Those are high-end terms I can really understand. How is Aubree as a patient, and how was it to see her in that story doing?
Incredible.
Yeah.
You can see how sweet she's. Incredible. She's been so stoic and so positive about her disease. It's been quite enlightening for her. Our patients who see her, she's like family now.
I bet.
Because everyone knows her up there.
Yeah.
And she's become quite the celebrity in our clinic.
I bet. Dr. Raghuveer, what's it like? Is this something that you treat for children, or is it children and adults? Tell us about that a bit.
Familial hypercholesterolemia is very common in children. It's about 1 in 250, as Dr. Moriarty said. It's very much underdiagnosed, and that's the problem. What Aubree has is a very serious case of familial hypercholesterolemia, where she picked up a bad gene from both the parents or mutated in such a way that she cannot really get rid of cholesterol at all. And I treat children with both, familial hypercholesterolemia, and I have 3 patients who've had what Aubree has in a very severe form, and they all come through the same channel. They come through dermatology. The skin bumps are ignored for a long time. They're misdiagnosed, or parents are given wrong advice. They may have had a cholesterol check, and they may have been told that it's all dietary, you need to cut the fat out. No amount of cutting the fat out or standing on your head is going to lower this, because it is genetic.
Well, I'm glad you said that, because I'm learning more about this as a parent of young kids, and you don't think about it as children having high cholesterol. So just so people understand, not lifestyle. This is something you're born with, correct?
Yes,
okay.
Absolutely. And it's very serious. What Aubree has is very serious. If she was not treated, she could have had a heart attack. She could die in the first 15, 20 years of age.
And if I'm Jade and I see those lesions and bumps on my kid, I'm calling my dermatologist. I mean, that would be the go-to.
That would be the right thing to do.
So how in the know is the dermatology field and specialty connected to this particular disease? And is there a better understanding so that people can get the right treatment?
I would say a well-trained and practicing dermatologist would recognize this quite readily. I would not be surprised. But there are situations where it's misdiagnosed. The good thing about Aubree, which you don't show in this video, is all of her xanthomas, those cholesterol plaques that you saw in her skin, they're all gone.
Yeah.
Since we've lowered her bad cholesterol, they've all dissipated.
Not removed.
Not removed.
They went away.
They just dissolved away because the source of them is the cholesterol. And if you take away the source, they just dissipate.
So explain what cholesterol is? We hear about it. It sounds bad. But what's good, what's bad, the ugly? Tell us.
Cholesterol is a major protein, lipid that's our body needs. We can't survive without cholesterol. Our cell membranes have a ratio of cholesterol to phospholipids. It's such an important product for our body, but there's so-called good and bad. And the problem is the bad cholesterol is what she has, and that's what's causing all this disease. But most cholesterol is so-called good. Bad is different. It has something called ApoB, which dictates its functionality, which can cause this kind of vascular disease. There's another cholesterol we talked about earlier that is also genetic, and that's called lipoprotein A, or LP(a). And that's not found in 1 in 250. It's found in 1 in 5.
Really?
In an African American population, the more commonly have it, 30% of them have this. And then presently, there's no drug that is available that lowers it.
So how do they get checked for it? How does somebody screen?
It's a simple blood test. In Europe and Canada, the European guidelines and Canadian guidelines, because it doesn't change throughout your life, it stays the same. The European Canadian guidelines recommend universal testing for everybody at least once in their life to see if they have it. Because if they don't have it, if it's not elevated, they don't have to worry about it. But if it is elevated, then you have to worry about it because you have to deal with your other risk factors that are at this point treatable. Our machines can lower this also by about 80%.
Dr. Raghuveer, how often are you treating children with this? And then how are you helping parents navigate and answer these questions? Because I'm sure they have a bunch.
So it's not uncommon because it's 1 in 250, and even if it's terribly underdiagnosed, they somehow come to my clinic, and it's mainly because there's something called universal lipid screening, which the pediatricians offer to all children, whether or not they have a family history of heart disease. And that's offered between age 9 and 11 years. So they get a lipid profile. They may not get a lipoprotein A, but the lipid profile is enough because that tells me that there's a high LDL cholesterol, and we take it from there. People like Aubrey needs to have their cholesterol checked at a younger age because 9, 10, and 11 is too old for them. They would have had a lot of heart disease developed by then.
So I have a 10-year-old. Does that mean she should get this screened? And how do I ask for it?
They should have been. Most pediatricians, the recommendations from the American Academy of Pediatrics is to do the lipid profile, irrespective of whether there is a family history of heart disease or not. But if they haven't had it done, you should inquire and make sure they have it done.
Okay, my kids, little bumps and skin irritations pop up on my kids all the time. They go away, no big deal. You're saying maybe take some of these skin bumps a little more seriously and have them checked? And who should check them?
I think these skin bumps, if they don't go away, that should be an indication that you need to get it checked.
Even if they're not orange like that? I mean, if my kid has that, I'm checking it out. But how do you know to get it quickly? How do I know what to have?
It's typically orange. It's typically yellow orange. It looks like what Mom described here, you know, like an orange sherbet.
It's going to look like that.
So it's very classic, very unique. So if the bumps go away, if it's a bruise and it's gone in a couple of weeks, I don't think you need to worry about it.
Okay, so you brought video showing how a clogged artery slows down the blood. Let's just look at this, see what's going on the inside.
Yeah. I hope you can see it. There are two artery models. The one on the right of the screen is the healthy artery, and the blood is flowing up and down very easily, and it got to the other side very quickly. The one on the left is the model which has the yellow stuff in it, and that's all cholesterol, and that's plaque, that's clogging the arteries. So you can see the red stuff, the blood, is not getting to where it should get to quickly. And this is what happens when people have heart attacks and strokes at an older age. But these kids who have the most severe form of familial hypercholesterolemia, it can happen as young as teen and early 20s. Yeah. So we need to diagnose early. We need to start treating early.
And you can just see in that illustration, if you're seeing that's going on the inside, there's a problem. There's a problem.
Yeah.
Dr. Moriarty, Jade, Aubrey's mom, had described another doctor kind of dismissing her concern. How do you know to push further and get that second opinion?
That's a good question. And it's up to the parent at this time. If they find the professional that they're seeing is not responding the way they think is appropriate, then they should get a second opinion. Like all people should do if they have doubts in their medical care. Second opinion is justified. It's like you're trying to buy a new car. You go to maybe more than one car dealer. But when it comes to this, it's even more higher priority. As Dr. Agravir brought up, the Pediatric Guidelines recommends testing for lipid panels, cholesterol, at a very young age for everybody as a screen, just to see if they have it. And if they don't have it, then that's one thing they don't have to worry about. Yeah. But it's not being performed.
I think the compliance with that is not 100%.
Right.
So that's concerning, and I don't know why that's the case, but there is more awareness since the guidelines came out amongst pediatricians, family doctors, to do this. So it's highly important for parents to understand that when they go for their annual checkups, they need to maybe talk about family history. If somebody in the family has had heart problems at a very young age, by young I mean less than 50, 45 years of age, and if that's the case, then maybe bring up cholesterol testing. It's very interesting that in my practice I see children who come in with high cholesterol and their parents have not had their cholesterol levels checked. So there's something called cascade screening in the adult world. So if they find an adult with familial hypercholesterolemia, you go around checking all the family members, including the kids. But I see the reverse in my practice. I see kids who come in with very high cholesterol. The parents are absolutely
in the dark,
terrified,
right.
And they're worried this kid is going to have a heart attack tomorrow. I tell them, come on, take a breath. It's not going to happen tomorrow. We will fix this. What is your cholesterol level? We don't know.
Well, this is why we do this program. It's not to scare people, but if hopefully people are learning alongside with me, because I have a 7 and a 10-year-old, and this is all new information to me. So I'm hoping people are listening and now know what to arm themselves with and what to ask doctors.
There's a website of a not-for-profit organization called the FH Foundation. And they're run by patients with FH and physicians like us. I'm on their board. They've been in existence for 15 years now. And they deal with FH, familial hypercholesterolemia, but also Lp(a). So it's very informative for lay people to get on this website. They have meetings and they have presentations and so forth. It's called FH Foundation. Highly recommend it.
So you talked about 1 in 250, that this is not rare, yet the treatment to get it is rare. We have one of the biggest facilities to treat this in the country, correct?
Well, yes, but 90-some-odd% of these patients are treated with medications.
Medications. They don't need?
No, they don't need these machines. Machines are for the limited few. This young girl, because of her genetic makeup, none of the medications worked at all. None of them did. Other FH patients, a lot of the medications can work. And there's a whole variety of medications out there now. There's statins, there's ezetimibe, these new injections called PCSK9 inhibitors that lower your LDL another 60%. So there's a lot of new drugs out there that are working. That's the future, we think. And there's now a new class that Dr. Agravir and I have been using that works totally different than all the ones that have been out there now. All the ones that are out now work on the LDL receptor by increasing the receptor to bring in bad cholesterol from the blood. This drug works totally different. It doesn't need the LDL receptors. So patients like Aubrey can respond to it.
So medication works when found early.
Yes.
She came to you, though, because it had gone on and it was...
No, but they tried medications on her. She was tried on all the medications.
And they weren't working?
They weren't working.
Yeah. Okay. She has a very serious form. And as Dr. Moriarty said earlier, even with that medication, it would have come down 50%. So 1,000 milligram to 400 or 500, that's still very high. So she needed that treatment, the apheresis treatment. I must tell you, medications are being used to lower cholesterol in children 8 and up, 8 years and up in in the pediatric world for the last almost 20, 25 years. They're very safe, they're very effective. Statins are very commonly used and they're very safe and effective, and they do not interfere with any growth or puberty issues. So I've had personal experience using them. And as Dr. Moriarty said, almost about 95% of the FH cases respond to medication. So it's the very rare and the most serious form where they don't respond to these run-of-the-mill medications that we need to try the experimental medication.
All right, be sure to ask your questions. You can use the chat on YouTube, Facebook. You can tweet us or email us at the Medical News Network. You can find that information right there on your screen. Let's get a check-in with Dr. Dana Hawkinson this morning. COVID numbers remaining low.
Low.
Yeah, low. All right. So, Doc Hawk, do you have numbers today?
Yeah.
Okay.
So today for our numbers, again, certainly lower than they have been. 7 active inpatients. Sorry, a little bit higher than they have been, but lower overall. So 7 active inpatients. And again, we have kind of transitioned because of the low numbers to presenting it a little bit differently, and really just talking about the active numbers, but still under 10, so that's a good thing as well.
All right. So, but a new strain of COVID is now the most common in the country.
Yeah.
It's got a nickname. It's called Eris. The doctors officially call it EG.5. It's another offshoot of Omicron. But does this new strain, does it change anything for patients or the providers who treat these patients? What do we know?
No, I think that's a good question. We've seen variants arise ever since SARS-CoV-2 started to circulate around the world. This is nothing different. This continues to be a variant of the Omicron lineage. So it's an Omicron sublineage, Eris. There really doesn't seem to be much change as far as clinical presentation, and certainly nothing as far as protection with preventive measures, such as, you can always wear a mask if you want to, if you're feeling unsafe in a situation. But certainly the boosters will still have effect. They will help boost your B and T cell immunity. And then, of course, the antiviral medicines will still be able to treat it. So really not much more new to talk about other than this new variant can certainly escape those antibody immune functions that we have, which is nothing new because we've seen all the other variants that preceded it also had that ability to escape a lot of the antibodies as well. But we do still expect the new monovalent booster to be effective at helping reduce your chance of hospitalization and severe disease.
All right, I have a question for you. Jeremy wants to know, when you're getting over COVID or some other infection for that matter, it's not super obvious. He's asking that you're done with it and it's completely out of your system. But how soon do you do things like swap out toothbrushes and other replaceable items and things like that?
I don't think there's any real good set amount or set state. Certainly, if you are fever-free for, 24, 48 hours, you can start to do it at that point. At that point, your body has really started to be able to take over and help reduce the amount of active viral replication that's going on. But I would say, at least starting maybe 24, 48 hours after you are fever-free without using any Tylenol. But there's really no good specific guidance on that answer there. So,
Dr. Moriarty has a question for you.
Yeah.
I have my nurse who was on a cruise in the Caribbean, and unfortunately her and the whole family developed COVID.
Yeah.
So she's back home now, but she's still symptomatic with a little fever and myalgias.
Yeah.
So my question is, once she's symptom-free, when can she come back to work here at KU?
Yeah, I think really the guidance for those types of things, those infection prevention guidance set out by the CDC is really, again, you want to be fever-free at least 24, 48 hours. Typically, you still need to be isolating at home for those first 5 days. After that, with a mask, you can return. And then, of course, specifically, you have to look at the, and this is for our audience out there, whatever maybe your institution's policy is for returning to work. I know certainly we have different policies based on if it's COVID or something else such as influenza. So.
All right, let's get to a couple more community questions that we have today. Pauline wants to know, what other conditions would require lipid apheresis, Dr. Moriarty?
Well, classically, patients have underlying vascular disease, meaning they had a heart attack, stroke, or some peripheral arterial disease. And those are 90-some-odd% of the patients we treat, and their LDLs are not at the level needed to be for control and prevention of future events. Now, when it comes to Aubrey, her numbers were so high, even though she didn't have vascular disease outside of the xanthomas. She did have a little aortic valve stenosis, but it wasn't enough symptomatically to be qualified. Her numbers were so high. And the guidelines is if you have disease with an LDL greater than 100 milligrams per deciliter on maximum pharmacotherapy. When it comes to Lp(a), the FDA approves if you have an Lp(a) greater than 60 milligrams per deciliter or 150 nanomoles per liter with ongoing vascular disease, and you qualify. The thing is, we're not using it as often as we should in this country. As I mentioned, how we have more patients than those larger cities combined. It's not because we have the patient population. We just have a great program here. And in Germany, they treat 10 times more patients with apheresis than we do in the United States.
What is that? Why is that, do you think?
And we're 6 times larger than them.
Right.
They're more actively involved with treating this disease than we are.
That says a lot.
It does say a lot. Germany's way ahead of us in this.
Yen Liang wants to know, do orange lesions have clinical symptoms, Dr. Raghuveer?
No, absolutely not, and that's the scary
tough.
part. I have a teenager who wants her orange bumps gone, but doesn't want to do anything else. She's probably not going to be compliant with any medications, and I'm having a hard time dealing with it. So it is more a cosmetic and an external thing, but painless, does not have any long-term sequela. It's going to go away, as we talked about, that the cholesterol comes down, the bumps go away, but it's more cosmetic.
What is considered high cholesterol, just for people as far as a lifestyle versus someone who has a genetic link to it?
Well, we used to think there was a level where LDL bad cholesterol is okay. We thought as a species we needed this bad cholesterol. But like tonsils and appendix, we've realized now we don't need them. There is no good bad cholesterol. All bad really is bad, has no physiological function. And if you listen to Goldstein and Brown, who are 2 physicians who won the Nobel Prize for discovering the so-called LDL receptor, they'll tell you that. They'll tell you LDL, which is the bad cholesterol, is a toxin, has no physiological benefit. And when most of us are born, our bad cholesterol, being LDL I'm using, is around 30 milligrams per deciliter. And if you need it bad, that'd be the most important time of life because you're replicating cells, but you don't. And there's no bad in the brain, it can't get in. The only cholesterol within the brain is good HDL cholesterol. The bad cholesterol, it can't cross the blood-brain barrier. So obviously we can't treat everyone to get down to 0 LDL, but as time goes on, we're going to be becoming more and more aggressive at treating this bad cholesterol because it has no benefit. It's like when someone has high blood pressure, do you wait till they have a stroke or a heart attack or kidney disease with the high blood pressure? No, you treat them right away. The same thing with other risk factors. You treat them right away. And we should be doing this more aggressively on these patients now because it's a preventable disease, as Dr. Raghuveer has been saying. It's treatable. And if you start now when they're asymptomatic, waiting 20, 30 years, you're not going to have problems. It's not going to develop because it takes decades for some of this disease to develop into its ugly self.
Diagnosing early and starting treatment early is the key. There are studies where they have figured out that if we start treatment at age 8 and 10, those kids, the arteries are preserved, they're healthy, and they don't get heart attacks and strokes when they're in their 40s and 50s. So that's key.
Great takeaway from our conversation. What else do you want us to know before we head out today?
I think everyone should know their cholesterol number. So if you don't know your cholesterol number, get it checked out. It's easy enough. It's like blood type. You need to know your cholesterol. Now, it can change from year to year, but generally if you have something very highly genetic, it's going to come out, it's going to be up there, so you can get treated. So I think universal screening, the adults should know, children should know. I would highly recommend that everybody know their cholesterol levels.
Knowledge is power. Dr. Moriarty.
And we're talking genetics, but also diet and exercise. Lifestyle has a major benefit. I tell my patients who have genetically high cholesterol, I say, you can't fight your genes. You're going to lose. But you can delay the final battle for decades if you start now by treating your lifestyle and also by treating your cholesterol. So it's important to initiate early and to live a healthy lifestyle.
Yeah, do what you can.
Yes.
Control what's in your control.
Exactly.
Any other takeaways you want us to walk out of here with today, Dr. Moriarty?
No, I think that was a very thorough coverage, and I think Dr. Raghuveer for coming in from Children's Hospital.
Thank you very much.
Yes.
I'm glad to be here.
Great conversation. Great conversation. How often do you two connect and talk? And
Not enough.
Not
Yes.
enough. Okay. Well, I'm glad I could bring these two together.
We work 5 miles away, but we meet at meetings.
Yeah.
We're out
Yes.
of town. So
And sometimes patients that are
Yes.
similar.
Yes. Yeah.
Very interesting
Emails,
topic.
yeah,
Like I
yeah.
said, I think I know I learned a lot. I hope our
Yeah.
viewers did too. So thank you both for being here today.
Thank
Our
you.
pleasure. Thank you for inviting
you.
us.
Thanks to all of our viewers for being with us today. We'll see you back here Wednesday at 8. Coming up Wednesday on Open Mics with Dr. Stites.
Older adults need 3 vaccines this fall: flu, COVID, and the first ever shot for RSV. I'm Alexis Del Cid. On the next Open Mics with Dr. Stites, we walk you through the complicated vaccine schedule with leading vaccine expert Dr. Gregory Poland. Wednesday at 8 a.m.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.